Fmge. Hello guys, I'm really sorry for the delay which has happened, right? So, hello, hello Raj Jakar, hello. Hello guys. So, hi Raj Singh, Vanilla, hi again. So, guys, we are really sorry for the delay which has happened. So, let us wait for 2 to 3 more minutes so that when sufficient students join, we shall continue taking the class. Okay. Hi Shweta, hello. So, hi Kaushal. So, we were discussing, right? So, were you all there, guys, in my previous class? Were you all there in my previous class? And even tell me from which university are you all? Hi Mohammed Yunus from Pakistan. Hi. Right, anyways, let us start, guys. Let us start. Right. So I'm fine. Sharfaraz, I'm fine. Sharfaraz, how are you? So guys, look here now. So we were discussing, like, in the previous class we have discussed that we have got two different types of tendons, right? We have got tendons, for example, flexor digitorum superficialis and flexor digitorum profundus. How many tendons of flexor digitorum superficialis are there? 4. And how many tendons of flexor digitorum profundus were there? 4, right? And this flexor digitorum superficialis attached to your middle phalanx. Flexor digitorum profundus went deep enough and attached to your distal phalanx, right? So all of them are responsible for flexion of your fingers, isn't it? Flexion of your fingers, of your digits, right? So you're clear with this till here, right? So you're clear with this. Now look here. Hi Medbooster, hello. Right. So look here now. That is the same thing I was telling you here, that lumbricales. What is the origin of lumbricales? Lumbricales originate from flexor digitorum profundus. Right. So how many tendons of flexor digitorum profundus we have got? We have got exactly 4 tendons. Right. So let us say this is one tendon of flexor digitorum profundus. This is the second tendon. This is the third tendon, and this is the fourth tendon. So 4 tendons of flexor digitorum profundus are there, right? Now from here the muscle starts. Now how does these muscle basically start is that, look here. From the first tendon we have got one lumbrical like this. From the first tendon we have got one lumbrical like this. From the second tendon also we have got a lumbrical like this, right? Now look at the third lumbrical. Third lumbrical is actually like this. This is third lumbrical. And look at the fourth lumbrical. So this is your fourth lumbrical. Okay. So how many lumbricals do we have here, guys? How many lumbricals do we have? We have got 1, we have got 2, we have got 3, and we have got 4. So 1, 2, 3 and 4 lumbricals are there. Why they are called as lumbricals? Because all of you know that we have got a parasite that is by named Ascaris lumbricoids, right? So that is a worm basically, right? So these are worm like muscles, that is why they are called as lumbricales. Okay, lumbricoid like muscles, Ascaris lumbricoid like muscles, so lumbricales we call it as. Okay, so we have got 4, but look at lumbrical 1 and lumbrical 2. There is only one part of lumbrical 1 and one part of lumbrical 2. So such muscles are called as unipennate muscles. But look at lumbrical 3 and lumbrical 4. Lumbrical 3 is like this, lumbrical 4 is also like this. So there are two penna, right? That is why it is called as bipennate muscle. So 1 and 2 lumbricales are unipennate, whereas 3 and 4 are bipennate muscles. Okay, 1 and 2 lumbricals are unipennate, 3 and 4 are bipennate. And if I ask you the origin of these muscles, they are originating from flexor digitorum profundus, right? Exactly speaking, tendons of flexor digitorum profundus, Is everyone clear? Yeah, they are arising from the tendons of flexor digitorum profundus. And out of all these 4 lumbricales, what is the nerve innervation? I told you in the starting itself. The first 2 lumbricales are innervated by median nerve. The next 2 lumbricales 3 and 4 are innervated by your ulnar nerve. Okay. So in the same way here, the first 2 lumbricales, it means unipennate lumbricales, they are innervated by median nerve. And the next 2 lumbricales are innervated by ulnar nerve. Clear everyone? Now, whenever I discuss about lumbricales, the first thing you have to do is that put your hand in this manner. Okay, put your hand in this manner. Now, what actions can you see here, guys? Anyone? Look here. Now, when you put your hand in this manner, these are your carpals, these are your metacarpals, and these are your phalanges. Okay, these are your carpals, metacarpals, and phalanges. Now, there is a joint between metacarpals and phalanges. This joint is called as metacarpophalangeal joint. So, this is extension of metacarpophalangeal joint. Now, this is flexion of metacarpophalangeal joint. Okay, flexion of metacarpophalangeal joint. Apart from this, between the digits also you have got what? You have got joints. So there is a joint here, there is a joint here. These are called as interphalangeal joints because it is in between the 2 phalanges, interphalangeal joints. So when I tell lumbricales, you have to put it like this, right? So there are only 2 functions: flexion of metacarpophalangeal joints, extension of interphalangeal joints. So this is the function of lumbricales. Okay, so lumbricales function is flexion of MCP joint and extension of interphalangeal joint. Flexion of metacarpophalangeal and extension of interphalangeal joint. So these are the basic functions of your lumbricales. Clear? Now, after discussing lumbricales, the nerve innervation and how the muscle looks, let us go on to the next one. What is that next one? Interossei. I have told you that we have got 4 interossei like this, right? We have got 1, we have got 2, we have got 3, and we have got 4 on the palmar side. These are called as palmar interossei. So these muscles which I'm going to write here are palmar interossei. The same thing we have got on the dorsal side. So these are called as dorsal interossei. So we have got 2 groups of muscles. One is called as palmar interossei. Another one is called as dorsal interossei. Okay. Now look at the palmar interossei. How does these muscles arise? Look here. All of you know this is the first metacarpal, second, third, fourth, and fifth metacarpal. Okay. Now palmar interossei arise like this. So one palmar interossei is like this. Okay. Look at the second palmar interossei. The second palmar interossei is also like this. The third palmar interossei is like this, and the fourth palmar interossei is like this. So these are how many palmar interossei? 4. 1, 2, 3, and 4. Now, what are the questions that they can ask? Palmar interossei are unipinnate or bipinnate, guys? Tell me now. Palmar interossei are unipinnate muscles or bipinnate? Come on. Medbooster, Sharfaraj, Mohammad Yones, Vanilla, Kaushal, Right, Shweta, I want you to answer. Palmar interossei are unipinnate or bipinnate? Be fast. Very good. No, Muhammad Yunus. It is unipinnate. Right, Dr. Lipan. Very good. Very good, Med Booster. This is unipinnate. Unipinnate. Very good. Unipinnate. The first point is it is unipinnate. Very good, Sarthak Jadhav. Very good. This is unipinnate. And second important question is they asked is palmar interossei are absent in which metacarpal? Which metacarpal do not have palmar interossei? You see the third metacarpal here. Does the third metacarpal to this third metacarpal is any palmar interossei attached? No. So look here. Third metacarpal does not have palmar interossei. Third metacarpal does not have any palmar interossei. Clear here? Now look at the dorsal interossei. Dorsal interossei are located here again between the metacarpals only. Now look how they are located here. This is the first dorsal interossei. This is the first dorsal interossei. This is the second dorsal interossei. This is the third dorsal interossei. And this is the fourth dorsal interossei. This is the fourth dorsal interossei. So again, how many? 1, 2, 3 and 4 dorsal interosseous. Now tell me, is dorsal interossei unipinnate or bipinnate muscle? Anyone? Is dorsal interossei a unipinnate or a bipinnate muscle? Very good. Shweta, very good. Palmar dorsal interossei are bipinnate muscles. Bipinnate muscle. Now the second question is, to which finger does this palmar interossei not attached? Look here very carefully. This is the confusing point here. See here, look at the second metacarpal. This is the second metacarpal, right? Or let us say this is the second metacarpal. Now, on the right side of second metacarpal, on the left side of second metacarpal, we have got palmar interossei. Look at the third metacarpal. This is your third metacarpal. On the right and on the left, we have got palmar interossei. Look at the fourth metacarpal. On the right and on the left, we have got palmar interossei. But look at the fifth metacarpal. Only on one side we have got palmar interossei, right? Exactly here. But on the other side it is absent. In the same way, look at the thumb finger, the first metacarpal. Only one side we have got, on the other side it is absent. So dorsal interossei are absent in which fingers? Dorsal interossei are absent in the first metacarpal as well as the fifth metacarpal. Is it clear, all of you? Dorsal interossei are absent in first metacarpal as well as the fifth metacarpal. Is everyone understanding, guys? Yeah, very good, Sharpraj. Very good. Now look here. One clinical point I want you to remember is that all of you know from where does the radial artery pass, guys? This is the place from where the radial artery will pass, right? This is the place from where the radial artery will come like this, isn't it? So this is passing all over like this. All over it is piercing here and it is coming onto the dorsal side, right? So exactly this radial artery is passing between what? Look here now. This is the radial artery which is coming all the way, and this radial artery is passing between the two heads of dorsal interossei, right? So where is this artery going? Radial artery is passing between the two heads of dorsal interossei. Okay, two heads of dorsal interossei. Keep this thing in mind. So what is the important thing? Radial artery passes between two heads of dorsal interossei. It passes between the two heads of dorsal interossei. Now, very good. Now look here. All of the following muscles are bipinnate except anyone? All of the following muscles are bipinnate except any answer, guys? Anyone? All the following muscles are bipinnate except Come on. Very good. Palmar interossei. Palmar interossei are not bipinate, but remaining all are bipinate, isn't it? Next important thing. Look at this metacarpal devoid of attachment of palmar interossei. Which metacarpal does not have palmar interossei? Come on. Which metacarpal does not have palmar interossei, guys? Palmar interossei are absent in, very good, third metacarpal, right? 1, 2, 3. The third metacarpal is not having palmar interossei. Okay, it is not having palmar interossei. Very good. Next important thing is that, guys, we have already studied the movements of the thumb. We have already studied the movements of the thumb, right? So all of you look here. All of you look here. This was a question which was previously asked. What was this? The thumb is responsible for opposition function, isn't it? The thumb is responsible for opposition function, and what was that muscle? Opponens pollicis, right? So thumb is responsible for opposition. Next important thing is that thumb is also responsible for adduction. I can adduct towards my body, isn't it? Thumb is also responsible for adduction, and thumb also performs extension. In these muscles which I have told you, I told you flexion, but I did not tell extension, because extensor muscle is not a part of intrinsic muscles. It is a part of the posterior compartment. Okay, so that is the reason why I am telling you now that when I am pulling a tendon like this, the muscle is getting extended, right? The thumb finger is getting extended. So this is an extension function. This is an extension function. Now, opposition function is done by opponent's pollicis. And what is the nerve that is responsible for opponent's pollicis, guys? Anyone? What is the nerve that is responsible for opponent's pollicis? Yeah, I want you to answer. Very good. Opponents is done by median nerve. Very good. Mohammed, very good. Opponents is done by median nerve. Median nerve. Very good. And adduction is done by which nerve? If you remember the muscles which I have told you here, right? Adduction, that is adductor pollicis. Adduction is done by which nerve? That is your ulnar nerve, isn't it? So adduction is done by ulnar nerve. Adduction is done by ulnar nerve. And extension is done by all the extensor muscles on the back are supplied by which nerve, guys? Which I have told you last class only. What is that nerve which is supplying all the extensor, which innervates all the extensor muscles? Yes, you need to be fast, guys. Very good. Radial. That is your radial nerve. So, guys, the three major nerves of upper limb, that is the median nerve. All of you listen now. The three major nerves of upper limb, that is the median nerve, ulnar nerve, and radial nerve. All these three nerves are responsible for the flexion, the extension, and all these functions of your thumb. So if I wanted to check all these three nerves whether they are functioning in a patient or not, simply I will tell him to flex his thumb, to extend his thumb, to adduct, to abduct, to do opposition function. So all these functions I will check just by moving his thumb. Just I'll be telling him to move his thumb. So because of that I can know which nerves are not working and which nerve is working. So this is the question which was asked, that is movement of which finger is used to test all the long nerves of upper limb. That will be your thumb. Okay, is that clear, guys? Is that clear now? All of you? Yeah. Maimun Sajid, are you clear with this? Dr. Lipun? Very good. Now let us move on to the next important topic, that is your carpal tunnel. Okay. Now, whenever you are looking at this carpal tunnel, the first important thing, first of all, carpal tunnel is located here the carpal bones, right? So what is exactly carpal tunnel? What is exactly carpal tunnel is that, look here now, look here now. You have got these carpal bones. So this bone, the last bone, this is called as your hamate. This is called as your pisiform bone, and this is your scaphoid, and this is your, what is this? Trapezium. Not trapezoid, this is trapezium. So there is a ligament. Okay, all of you now listen carefully. There is a ligament which attaches all the way from hamate to pisiform, trapezium to scaphoid, and all the way this is the ligament. This ligament is forming like a roof. Okay, this ligament forms like a roof like this. Okay, so this is the ligament, and this ligament is transverse in nature, so I can also call it as transverse carpal ligament, or the other name is flexor retinaculum. What is this ligament called as? Transverse carpal ligament or flexor retinaculum, where it is attached to the trapezium, scaphoid, pisiform and hamate. Okay, so this one over here is called as transverse carpal ligament or flexor retinaculum. Flexor retinaculum. Okay, now look here. What is median nerve? Median nerve, how does it pass? Look here. Median nerve all the way comes like this, right? And it passes beneath the flexor retinaculum and comes out like this. Okay, median nerve passes beneath the flexor retinaculum, comes out. So it means, for example, here I have got my flexor retinaculum like this. If here I have got my flexor retinaculum, the median nerve comes all the way, it passes beneath the flexor retinaculum and it comes out like this. Okay, now here what will happen? Median nerve supplies in the hand. Median nerve supplies to how many muscles, guys? Tell me. Median nerve supplies to how many muscles? I have already told you. In the thenar region, the first three muscles are supplied by median nerve, right? It gives a branch that is to the thenar muscles. Thenar muscles. Except which muscle? Which muscle does it not supply? Anyone? Which muscle does the thenar? Which muscle does the median nerve does not supply? Which muscle does this median nerve does not? Very good, very good. This is your, come on, it is all over here, guys. Look here. It does not supply your adductor pollicis, but it supplies all the first three, isn't it? So it does not supply except adductor pollicis. It supplies to everything. Okay. Next important thing, thenar nerve also supplies to which lumbricals, guys? Remind me. It supplies to 1 and 2 lumbricals. It supplies to 1 and 2 lumbricals. Okay. And third important branch. Now here is the one which gets little tricky. All of you listen now. Third important branch is the digital nerve. So this nerve which is coming all the way like this. This nerve which is coming all the way like this. This nerve is called as digital nerve. Why it is called as digital nerve? Because it supplies to the digits. It supplies to your fingers. Okay, it supplies to your fingers. Then what about the palmar region? Because all of you know, if you look at the picture below, all of you know that this blue color one is called as a median nerve. So median nerve is supplying your fingers. It is also supplying the palmar region. So fingers are supplied by digital nerve. Then palmar region is supplied by another nerve. What is that nerve? Anyone? Any idea? Because very important clinical point is going to come now. Look here now. This is your median nerve, right? So from this point, there is a branch that is going all the way. There is a branch that goes all the way like this, right? Now this branch is passing on to the roof of flexor retinaculum and it supplies to your palmar region. And this branch, you call it as palmar cutaneous branch. Palmar cutaneous branch. Okay. Now, why did I give you such a long explanation? The reason why did I give you such a long explanation is that, keep in mind one thing. If there is carpal tunnel syndrome, all of you know in carpal tunnel syndrome, median nerve will be compressed. So when median nerve is compressed, patient will complain of what? Patient will complain that his thenar muscles are not working, his lumbricals are not working. Okay. Second important thing patient will complain is that his digital nerve is also not working. So if his digital nerve is not working, then what will happen? Patient will complain that he is having tingling sensation in the digits. Okay, in the fingers he is having tingling sensation. But when you ask in the palmar region, how is it going? Patient will complain that palmar region has got no complaints. Palmar region is absolutely perfect. Why? Because palmar cutaneous branch does not pass underneath flexor retinaculum. It passes above the flexor retinaculum. So in carpal tunnel syndrome, which is the nerve that is not involved? That is palmar cutaneous branch of ulnar nerve. Is everyone clear with this explanation, right? Everyone, guys? Right. Now they're gonna ask you what are the contents. They're gonna ask you what are the contents of the carpal tunnel. Now, what will be the contents of carpal tunnel, guys? Can anyone tell me? Look here, the first important thing. The first important thing is that we have previously discussed that there are 4 tendons going like this. What are those 4 tendons? Tendons of flexor digitorum superficialis. We have 4 more tendons that are going. What is that? Flexor digitorum profundus. Okay, and there is one more tendon that is going all the way and it is attaching to your thumb. That is called as flexor pollicis longus. So we have discussed this in the previous class itself. Look here, we have discussed this in the previous class itself, that this is flexor digitorum profundus, right? This is flexor pollicis longus. So all of them here, they are passing beneath your flexor retinaculum. All of them are passing below your flexor retinaculum. Okay, so keep this thing in mind. All of them are passing below your flexor retinaculum. And fourth important thing is that even median nerve is also passing through the flexor retinaculum. So what are the contents of flexor retinaculum, or what are the contents of the carpal tunnel? Are flexor digitorum superficialis, profundus, flexor pollicis longus, as well as the median nerve. Okay, so these are the contents which are located within the carpal tunnel. Is everyone clear, guys? So this is all you need to know regarding the carpal tunnel. Second important question they are going to ask you is, then what are the structures that are passing superficial to carpal tunnel? What are the structures that are passing superficial to carpal tunnel? Yes, tell me, what are the structures that are passing above the carpal tunnel, guys? The first important structure that is passing above the carpal tunnel, look here very, very clear. Superficial to carpal tunnel. S stands for superficial, U stands for ulnar nerve, and P stands for palmaris longus. And obviously you should not forget the third one is palmar cutaneous branch of your median nerve. Okay, palmar cutaneous branch of what? Palmar cutaneous branch of your median nerve. So these are the 3 structures that are passing superficial to your flexor retinaculum. Okay, so is everyone clear with this? So this is the thing, guys. This is the thing over here which you have to learn here. Yeah. So this will be your scaphoid here, right? All the way. This is your hamate, and there is a ligament that is attached all the way like this, right? So what is this ligament? Anyone? This is called as transverse carpal ligament, or you also call it as flexor retinaculum. Okay. So this is called as flexor retinaculum. This is called as flexor retinaculum or transverse carpal ligament. Okay. Next important thing is that the nerve which passes in the center here, this is called as median nerve. What is this nerve over here? This is called as median nerve. This is called as median nerve. Along with median nerve, I have already told you flexor digitorum profundus, superficialis, and flexor pollicis longus also, they pass through that. Clear? Is everyone clear, guys? Very good. Next important thing is that if patients is having carpal tunnel, you do two important tests. What are those two important tests which you do? Look here. What you do is that you catch hold of the fingers of the patient, and if patient is complaining of severe pain, you catch hold of the fingers and then you extend his wrist like this. After extending his wrist, what you do is that you press in this carpal region. Okay, you press here. When you press this region, patient will have pain in this area. If patient is having pain in this area, it means patient is having positive Tinel test. This test is called as Tinel test. This test is called as Tinel test. Second important test you need to know is that you need to tell the patient to flex his wrist and put it like this. Okay, so you need to tell the patient to flex his wrist and put it like this. So if patient is experiencing, because when you are compressing the wrist, the median nerve will be compressed, right? So if patient is having pain and numbness in his fingers, it means patient is having positive Phelan test. What is this? Positive Phelan test. Positive Phelan test. So we have got two tests. One is called as, what is this? This is called as Tinel test and this is called as Phelan test. Is everyone clear with this? Now, next important thing you need to know here is that how these nerves get supplied. All of you look here, guys. How these nerves get supplied here. Look here. This blue color nerve which you can see, this blue color, this is the area where what? Median nerve is supplied. This is the area where median nerve is supplied. Okay. Now look here. Median nerve comes all the way like this. Median nerve comes all the way, and here it gives branches. One branch it gives to the fingers. What is that? Digital branch. Next, above the flexor retinaculum, it comes all the way and gives to the palmar region. So patient will complain that he is having pain in the fingers, tingling sensation in these fingers, but he is not having any kind of pain or tingling sensation in the palmar region. Okay, so you know the answer why. Clear? Next, this black color thing, whatever is there, is your ulnar nerve. Ulnar nerve supplies ventrally and even dorsally also. Ulnar nerve supplies this area. Okay, ulnar nerve supplies this area. And this red color thing which you can see here, what is this nerve? This is called as your radial nerve. This is called as your radial nerve. Okay, how do you remember this? Right? Oh, sorry, this is again RU. Okay, UMRU. So what is this? From the medial side, UMRU, umru. Umru in the sense death. In Russian, you call it as death. Okay, umru in the sense death. So remember like this, U, M, R and U. Clear? So this is the important thing which you need to understand here. Right? I hope all of you are clear with this. Right? Let us go on to the next important thing. What is that next important thing here? See here, the same thing is also given over here. So this is U, M, and on the back we have got R and we have got U. Okay, so if median nerve is compressed, only this blue area will be in trouble. Right. Let us go on to the next. Let us go on to the next here. The most important point I'm going to tell you here, guys. Look here very carefully. Concentrate on this muscle. What is this? Flexor pollicis longus. And where is this flexor pollicis longus attached? It is attached to your distal phalanx. Okay, it comes all the way and it attaches to your distal phalanx. Okay, so this is your flexor pollicis longus, comes all the way and attaches to your distal phalanx. What is this? Flexor pollicis longus. There is a next muscle. What is that? Another muscle, flexor pollicis brevis. I told you the thumb finger flexion is done by flexor pollicis brevis. And where is that muscle attached? Look here. Flexor pollicis brevis is coming like this. It is coming all the way and it is inserting to your proximal phalanx. What is this muscle? This is called as flexor pollicis brevis. Flexor pollicis brevis. Now, why am I telling you this? Because there was a question which was asked, guys. What is this question? Is that between the two phalanges, the joint which I have between the two phalanges, this is called as interphalangeal joint. And the joint which I have between the phalanx and metacarpal, this is called as metacarpophalangeal joint. Okay, so it means Flexor pollicis longus is responsible for flexion of interphalangeal joint. It means it is responsible for this function. Whereas flexor pollicis brevis is responsible for this function. Okay, this is flexor pollicis brevis. This is flexor pollicis longus. Clear? Why am I telling you this? Because all of you know that you have got a nerve like this. What is the name of this nerve? Median nerve. This nerve is called as median nerve. Now, median nerve, normally it supplies to your flexor pollicis brevis, because we have already talked in the thenar muscles that flexor pollicis brevis is supplied by median nerve. Okay, but what is the interesting thing? Interesting thing is that median nerve also gives a branch, and that branch supplies to flexor pollicis longus, and the name of that branch is, what is that branch? Anyone? Anterior interosseous nerve. What is that nerve? That is your anterior interosseous nerve. Anterior interosseous nerve. Okay, why are you telling this? Why am I telling this is, keep it in mind one thing. For example, if I have injury at the level of anterior interosseous nerve, then only one function is lost, that is function of flexor pollicis longus. It means I cannot flex the interphalangeal joint. But if there is a high median nerve injury in the sense, the top, at this region, if there is a injury, then median nerve is not working, anterior interosseous nerve is not working. It means metacarpophalangeal joint I cannot flex, interphalangeal joint I cannot flex. So there is complete loss of flexion of this entire finger. I hope is it clear for you? If I am not able to flex only interphalangeal joint, that is a problem with anterior interosseous nerve. If I am not able to flex interphalangeal and metacarpophalangeal, that is a problem with the median nerve. So, one very important thing you need to remember is that high median nerve injury, right? In this, MCP and IP, both of the flexions are lost. Guys, still here, is everyone clear? Yeah? Right. Very good. So this was a question which was asked. What is this question? Which of the following action will be restricted if anterior interosseous nerve injury happens? If there is injury of anterior interosseous nerve, which function will not happen? Tell me. I need your answers. Come on. Adil, Lipun, Muhammad Yunus. Very good. Dr. Lipun, perfect. Dr. Lipun is telling flexion of interphalangeal joint will not happen. Very good. Flexion of interphalangeal joint will not happen. Okay. Clear, everyone? Right? Now look at this important point here. What is the important point which I'm going to tell you is that, all of you now concentrate. Look here now. We have got a tendon, I told you, right? That is coming all the way like this. What was this tendon I told you? Flexor pollicis longus. This is flexor pollicis longus. And we have also got 4 tendons. That is flexor digitorum superficialis and flexor digitorum profundus. Okay. So this is one tendon, this is the second tendon, this is the third tendon, and this is the fourth tendon. Okay. So all these are the tendons of flexor digitorum superficialis and profundus. I mean, I cannot draw 8 tendons here, so simply I have drawn 4 tendons, telling you that this is flexor digitorum superficialis and profundus. Okay. So this is flexor digitorum superficialis and flexor digitorum profundus. Now surrounding these tendons, this is a very important clinical point. Look here. Surrounding these tendons, I have got a synovial sheath. Okay. What is this? This is called as a synovial sheath. synovial sheath surrounding these tendons. So surrounding this tendon also I have got a synovial sheath. Surrounding the next tendon also I have got another synovial sheath. Surrounding the third tendon also I have got another synovial sheath. But look at the fourth one here. Surrounding this I have got a synovial sheath like this. In this way. Can you clearly look out the differences, guys? Flexor pollicis longus is having a separate synovial sheath. The first finger, the second finger, third finger, fourth finger. These three fingers are also having separate. But look at the fifth finger, the synovial sheath is covering all the four tendons, right? So, the space between the tendon and the synovial sheath, this empty space, whatever is there, this is called as bursa. Okay, so it is on the radial side. This is called as a radial bursa. If it is on the ulnar side, this is called as ulnar bursa. Radial bursa as well as an ulnar bursa. Okay, so bursa is nothing but an empty space. This is nothing but an empty space. Why am I telling you this? Why am I telling you this is that whenever you visit a hospital for a blood checkup, let us say for a ABO grouping, okay, for to know which type of blood group you are with. So to check that, what do you do basically? They basically use these three fingers. They basically use these three fingers to prick. They don't use the thumb finger and the little finger. Why? If they use the little finger, by chance, if there is any kind of infection that entered here, that infection will pass down through the entire bursa and it will infect all your four tendons. In the same way, if they prick in the thumb region and if there is any infection, the infection will completely spread onto your flexor pollicis longus tendon. But if they prick in the index finger, middle finger and the ring finger, what will happen is that the infection is limited only till here. The infection is only limited till here. So you can cut it down and drain out the pus, right? But it does not pass all the way down here till the flexor region. Clear, everyone? Right? And infection of this synovial sheath is called as tenosynovitis. Clear? Infection of this synovial sheath is called as tenosynovitis. Okay. Now, sometimes it might happen like this. What is that important thing? Sometimes it might happen like this, that this synovial sheath can swell. When the synovial sheath will swell, what will happen, guys? Inside there is tendon. The tendon will be compressed or not? When there is complete swelling of this synovial sheath, the tendon will be compressed. Right? Bursa between Muskan Kapoor, I was telling you that this is your ulnar bursa. Okay, this is your ulnar bursa, this is your radial bursa, and these bursas are separate bursa of your second, third, and fourth finger. Okay, these are your separate bursa. Right. So if there is infection, if there is swelling of the synovial sheath, what will happen is that the tendon inside might get compressed. So one example I'm going to tell you guys, what is that one example is that if you can look at this picture clearly, you can see two tendons. So this is tendon number 1 and this is tendon number 2. And tendons are covered by this blue color layer. This is nothing but called as synovial sheath. And what are these tendons? There are two tendons here. Abdul Ka X. What is Abdul Ka X? Abdul Ka X. Whose is Abdul Ka X? Abdul means abductor pollicis longus. X in the sense extensor pollicis brevis. So these two tendons are abductor pollicis longus and extensor pollicis brevis. So if the synovial sheath is inflamed, it is swollen, then it will compress these two tendons. If it is compressing these two tendons, then what will happen is that patient cannot abduct his thumb, he cannot extend his thumb. Okay, abduction and extension of the thumb is lost, and this condition you call it as decurvain tenosynovitis. So this was a question that was asked in decurvent tenosynovitis. What are the two muscles which are involved? What are the tendons which are two involved? What are the two tendons? Abductor pollicis longus and extensor pollicis brevis. Did you understood everything which I've taught you guys? Yeah? Come on. Don't be dull. I want your response. Only Adil is answering. Mehul, yes, Mehul. Not this depth, but at some extent it might be even useful for you. Right. Hope all of you are understanding. Right. So if a patient is having decurvent tenosynovitis, what is the test? How do you check? How do you check? Is that simple thing? What you do is that you close the thumb, make a fist, and then tell the patient to bend his wrist in this way, right? So what you do is that you catch hold of the wrist and bend it like this. When you bend it like this, if patient is having severe pain here, very severe pain, he will immediately take back his hand. If he's not taking back, because if he's taking back, it means there is severe pain in this region. So this is called as positive Finkelstein test. What is this test here? This test is called as Finkelstein test. Finkelstein test. Very good. Akib. Perfect, Akib. Very good. Okay. So guys, this covers maximum amount of your MCQs. Maximum amount of your MCQs. But still, we shall be doing MCQ after each and every topic. These are the MCQs, not my MCQs. These are the MCQs which were previously asked in your exams. Okay. So decurvent tenosynovitis results from the inflammation of synovial sheath of what tendons? Can anyone answer this? Yeah. Akib, Dr. Lipon, Muskan Kapoor, Abhay Khairati, Abhay, why it is C? Extensor digiti minimi, no Abhay. Look, very good. Very good, Adil, TV Beast. Very good, Muskan Kapoor, very good. Answer is A. It is abductor pollicis longus and extensor pollicis brevis. Very good. Now, next important and the most difficult to understand, most difficult topic to understand, that is your spaces of your hand. Right? So I want to look here. I want to explain this so clearly, as easy as possible. But I want you to put your pens down. Don't write anything. Just focus on what I'm teaching. Good evening, Mohammad Razik. Good evening. All of you, look here, guys. Now, here, spaces of the hand. Now, there are two different types of spaces. There are two different types of spaces. Okay. One space we have got in the center. In the center of the hand, we have got a space. This is called as mid-palmar space. And we have got another space in the thenar region. This is called as thenar space. Thenar space and mid-palmar space. Okay. So we have got two spaces, palmar spaces and dorsal spaces. Clear? Now what is this palmar and dorsal spaces? Palmar spaces are two. Thenar, mid-palmar. Dorsal spaces are on the back. I will tell you what is that. So for now, palmar spaces are two. One is called as thenar, another one is called as mid-palmar. Mid-palmar. Now you can look at this picture in the center here. This is called as mid-palmar space, and whereas this is called as the thenar space. Now let us look into these spaces. For example, if I am cutting down my hand like this, and if you are looking through the cut portion, what are the structures you can see? I'll be drawing it right now, and then I'll show it to you later on. Clear? Now look here. All of you pay attention here. All of you pay attention. When I'm putting my hand like this, right side thenar, left side hypothenar. Okay. So right side, I have got thenar muscles like this, and below that, left side I have got hypothenar. Okay. So this is my thenar muscles, and this is my hypothenar muscles. Clear? Between the thenar and hypothenar, What do I have? Metacarpals. Thenar is sitting on the first metacarpal. Hypothenar is sitting on the last metacarpal. And in between I have 2, 3, 4 metacarpals, right? So look here. Thenar is sitting on the first metacarpal. Hypothenar is sitting on the fifth metacarpal. And in between I have got 2, 3 and 4. 2, 3 and 4 metacarpals. Clear? Right? Next important thing. Attached to the metacarpals on the dorsal side, one metacarpal is attached to another metacarpal with the help of muscles here. What are these muscles, guys? I have already spoke about these muscles. Can anyone tell what are these muscles? Be fast. Yeah? Come on, guys. I want your full attention over here. What I was asking is, between the metacarpals on the dorsal side, we have got muscles in between the metacarpals. What are the? Very good. TV Beast is telling that dorsal interossei muscles. And also I told you previously that dorsal interossei are bipinnate muscles, not unipinnate. They are bipinnate muscles. If you remember what we have talked previously, right? Look here. Bipinnate muscles, right? Dorsal interossei are bipinnate muscles. So the same thing I'm going to draw here now. The same thing I'll mention it here. Okay. So they are bipinnate like this. 2 pinna are there. Here also 2 pinna. Here also 2 pinna. And here also 2 pinna I have got. Bipinnate muscles. Clear? Third important thing. Everything will come to a sense, guys. Don't worry. Just concentrate here. Muscles are covered by what? Fascia. Then all these dorsal interossei, the thenar muscles, the hypothenar muscles, all of them should be covered by fascia. Look here now. So all these muscles, they are covered by a beautiful fascia like this. So you call it, if you want, you can call it as fascia, or you can also call it as aponeurosis. Aponeurosis or fascia, right? Both of them are, they have differences, but most of them are same. Okay, right? Now touching one fascia to another fascia, one end of the fascia to another fascia, you have got a fascia like this. This is called as palmar aponeurosis. Point number 1 to remember. This is called as palmar aponeurosis. This is called palmar aponeurosis. Clear, everyone? Now look here. Look here now. From the palmar aponeurosis to the fifth metacarpal, from palmar aponeurosis like this to the fifth metacarpal, I have got a septum that is attached. From the palmar aponeurosis to the first metacarpal, I have got another septum that is attached. Now, what are the names of this septum? Look here. This septum is towards the hypothenar region. What is this side, medial or lateral side? This is my medial side. This is my lateral side. Okay. So this septum is present on the medial side. So I call it as medial palmar septum because it is on the palm. Medial palmar septum. So other one will become lateral palmar septum. Lateral palmar septum. Okay. Okay, forget about medial and lateral. If I draw a septum in the center, all the way from the palmar aponeurosis till the third metacarpal, if I am drawing a septum like this will become which septum? In the center it is called as intermediate septum, isn't it? So this septum I call it as intermediate septum. This septum I call it as intermediate septum. Clear, all of you? Right. What you do is that you cut down this area. When you cut down this area, skin. After the skin, you will find fat, subcutaneous fat. After the fat, you will find this layer called as palmar aponeurosis. When you cut down the palmar aponeurosis, deep inside, you will find an arch like this. You will find an arch. This arch is called as superficial palmar arch. When I teach you about the arteries of the upper limb, that time I will tell you what is superficial palmar arch. Okay. This is called as A. Okay. A stands for superficial palmar arch. Okay. Now, deep inside the superficial palmar arch, deep inside that, we have got 4 tendons here. You remember, we have got 4 tendons. Tendons of what? Flexor digitorum superficialis and flexor digitorum profundus. No surprise, right? We have got 4 tendons. Let us say 1, 2, 3 and 4 tendons. These empty tendons are tendons of flexor digitorum superficialis. Now, this tendon which I am completely coloring it up, these are the tendons of flexor digitorum profundus. Clear? So, this is flexor digitorum superficialis and this is flexor digitorum profundus. TV Beast is telling screen is not showing up. Is everything okay now? Now okay, right? Now okay, fine. So this is flexor digitorum profundus. Okay, and previously I told you flexor digitorum superficialis and profundus are completely covered by a bursa. I told you, remember that? Look at the previous picture. Flexor digitorum superficialis and profundus are covered by a bursa like this. What is this bursa? Yes, tell me, what is this bursa? Ulnar bursa, right? Or radial bursa? Radial or ulnar bursa? Very good, Muskan, very good. Ulnar bursa. So that the same thing I'm gonna do here is that flexor digitorum superficialis and profundus are covered by this pink color bursa here. This is called as ulnar bursa, right? So what is this bursa? Ulnar bursa. Ulnar bursa. Okay. Naresh, notes I will immediately once I finish up the upper limb, I will post the notes completely. Okay, in a single folder, in a single PDF, I will post it. Okay. So this is ulnar bursa. Clear? Next important thing, lumbricales are attached to flexor digitorum superficialis or flexor digitorum profundus. Tell me. Lumbricales are attached to flexor digitorum superficialis or flexor digitorum profundus, guys. Very good, Muhammad Yunus. They are attached to flexor digitorum profundus, right? So look here. And by the way, in the starting itself, I told you that first lumbrical will have unipinnate, second lumbrical is also unipinnate. But look at the third and the fourth. Third lumbrical is bipinnate, fourth lumbrical is also bipinnate. You know this, right? Obviously, you know this. Clear? Done. Now look on to the other side now. Look on to the other side. Here, this thing, let us come from superficial to deep. Okay. If I ask you, what is this space? This space which I have just told you, this is called as mid-palmar space. This space which I have just told you is nothing but called as your mid-palmar space. Okay. So if I ask you from superficial to deep, what are the structures? The first one is palmar aponeurosis. Okay. Look here. The first one would be palmar aponeurosis. Palmar aponeurosis. Just beneath the palmar aponeurosis, I have got what? Superficial palmar arch. I have got superficial palmar arch. Just beneath the superficial palmar arch, what do I have? I have got ulnar bursa. What do I have? I have got ulnar bursa. And just within the ulnar bursa is covering what? Tendons of flexor digitorum superficialis and flexor digitorum profundus. If I go little bit deep enough, what can I find? I can find lumbricales. Lumbricales. What are the numbers of the lumbricales here, guys? This is 1, this is 2, this is 3, this is 4. I can find lumbricales of 2, 3, 4. Right? Not 1, 2, 3. 2, 3, 4 lumbricales. Lumbricales. Okay. Still more deep if I go, I will find dorsal interosseous. Isn't it? Still more deep if I go, I am finding this dorsal interosseous. And still more deep if I go, then I will find what? What will I find? I will find the fascia. I will find the fascia. So from the superficial to deep, it means if you are drilling a hole into my palm, what is the first layer you touch and what is the last layer that comes out? This is the superficial to deep structures which they will ask you in the exam for sure. Did everyone understood this mid-palmar space? By the way, this space is called as mid-palmar space. This space is called as mid-palmar space. Did everyone understood what is mid-palmar space, guys? Yeah? Clearly, without any doubts. Right. Next important thing. Next important thing is that we have discussed a tendon that is going and attaching to your distal phalanx like this in the flexor in the palmar region like this. What is this tendon, guys? This tendon which I'm highlighting right now, this is called as flexor pollicis longus, right? Where is it present? It is crossing the thenar region. It is present in the thenar region, right? So the same thing I'm going to draw it right now. Same thing I'm going to draw, that this tendon is flexor pollicis longus tendon. What is this? Flexor pollicis longus. And flexor pollicis longus is surrounded here by what bursa? Flexor pollicis longus is also surrounded here by bursa. What is that bursa? Tell me. Yeah. Very good, Dr. Lipan. Very good. Radial bursa. It is surrounded by radial bursa. So what I will do in my picture is that I will also put a radial bursa surrounding this. Now I am going to ask you a question. From superficial to deep, what are the structures? First, I have got palmar aponeurosis. Second, I have got radial bursa, right? So let me write it down. First, I have got palmar aponeurosis. Just beneath that, I have got radial bursa. Radial bursa is enclosing what? Flexor pollicis longus. Then below that I have got tendons. One is flexor digitorum superficialis, another one is flexor digitorum profundus. So below that I have got tendons. Tendons of flexor digitorum superficialis, flexor digitorum profundus. And attached to flexor digitorum profundus, I have got first lumbrical, right? So first lumbrical I have got. And next important point you have to keep it in mind. What is that very important point is that? Look here now. Attached from first metacarpal to third metacarpal, I have got a septum like this. I have got a septum. What is this septum doing is that just behind this septum, I have got a muscle like this. Just behind the septum, I have got a muscle here. And the name of this muscle is adductor pollicis. Adductor pollicis. So adductor pollicis is covered by a fascia or a septum, right? So if I go little bit deep enough, what will I find? I will find fascia covering adductor pollicis muscle. Adductor pollicis muscle. So these are the important spaces. These are the important spaces which you need to know. Okay. Superficial to deep, what are the structures present in the mid-palmar space? Superficial to deep, what are the structures that are present within your thenar space? So this pink color space which I am highlighting, this is called as your thenar space. That yellow color space which is there, that is called as mid-palmar space. Now you know superficial to deep, what are the structures that are present. So the same picture I have kept it here because whenever, you know, when I'll be uploading the notes, so that this picture will be like a practice to you. The same structures are here, nothing different. Okay, everything is same. Okay, so you told me about thenar space. You also told me about mid-palmar space. Then what about dorsal spaces? Dorsal spaces are very easy. Look here. Look here now. What is the outermost layer here? Outermost layer, skin, right? So this skin is the outermost layer like this. Okay. Now, just beneath the skin, whatever area I have here, this is called as subcutaneous space. Subcutaneous space. Next, after the skin, I have got fascia or aponeurosis, and beneath the aponeurosis, whatever space I have, this space here, right, beneath the aponeurosis, this is called as subaponeurotic space. Subaponeurotic space. So these two spaces are located on the dorsal side, right? So subcutaneous space and subaponeurotic space are called as your dorsal spaces. Clear? These are called as your dorsal spaces. Is everyone clear with this explanation, guys? Yeah? All of you? Are you clear with this? Whatever I've just explained you? Yeah? Let me take a minute and ask everyone that did you understand before I go to the next one, because we have covered. Mohammed Yunus, you understood, right? TVD Beast. Very good. Lipun. Lipun, you understood? Dr. Lipun. Fawad Alam. Have you understood, Fawad? Yeah, it is a little bit hard. It is a little bit hard, but when you study it, you will understand it immediately. Okay. Now, there is one more space. What is that space? That space is called as pulp space of the digits. It means, yes, I'll start immediately after this. I'll be starting the lower limb, and after that immediately I'll complete with the thorax. Okay, don't worry about that. Definitely I will teach you thorax, and only then I'll stop this session. Okay. So coming to the pulp space of the digits, I'm drawing this part of my finger. Okay, this part of my finger. Look here very carefully. Right. So this is the index part of the finger, right? So let us say this is your nail. This is your nail over here. This is the index part of the finger. Now, when you look at the distal end, exactly here, guys, when you look at this distal end, what has happened is that in the distal end, from the bone to the skin, you have got lots of septa like this. You have got lots of septa. Okay. So these septa are dividing this region into loculi, and within this loculi, what do we have? Within this loculi, we just have subcutaneous fat. This is between this loculi, we just have subcutaneous fat. What is this? Subcutaneous fatty tissue. We just have subcutaneous fatty tissue. Okay, and this space, whatever we find between the loculi, this space is called as pulp space. Pulp space. Why am I telling you this? Why? And one more point, that there is an artery which comes all the way like this and supplies here. Okay, this artery is called as distal artery or digital artery. This artery is called as digital artery. Why am I stressing you on this? Because fingertips are the one which are more commonly prone to any kind of injury, right? So either it might be heat or trauma or whatever it is, fingertips are more exposed to injuries, isn't it? So mostly whenever this fingertip is injured, and if you are not treating it, if you have completely left it, then what will happen is that the infection will enter and settle inside the loculi. So infection will enter into one loculi like this. From here, the infection will pass on to the second loculi. In this way, your entire pulp space will be infected. So if there is a lot of pus in this pulp space, that condition, you call it as Whitlow. Whitlow, or you also call it as Phelon. Phelon or Whitlow is nothing but pus within the pulp space of the digits. Okay, it is nothing but pus in the pulp spaces. Pulse in the pulp space is called as Whitlow or Phelon. Okay. Now, what will happen because of this? Still, you have got a time. because if you are still not treating it, that infection will enter into this digital artery, right? Once if it enters into this digital artery, that infection will block this digital artery at multiple places. When it will block here, the blood supply will not happen to the distal region. So when the distal phalanx is not receiving sufficient amount of blood, that will undergo a condition called as avascular necrosis. What will that undergo? That would undergo avascular necrosis. So the examiner will ask you a question that a complication of Whitlow is avascular necrosis, or avascular necrosis is a complication of Whitlow. Okay, so if you can look at this picture here, I hope many of you have gone through this condition. So this is called as the Whitlow. There is a lot of pus. So what you need to do? What you need to do is that you cannot cut the finger in the center here. If you cut the finger in the center, only one loculi will open. Actually, lots of loculi are like this. So what you do is that you cut it transversely here. When you cut it transversely like this, all the loculi, all the septa will be opened, so that you can immediately drain the pus. Clear? Right? Did everyone understood? Right. Next important thing, guys. Very good. You understood, right? So majorly we have got three. Majorly we have got three pulp spaces. One is the pulp space of the digits. I mean, not pulp spaces. Majorly we have got three spaces. One is called as the mid palmar space. Another one is the thenar space, and the pulp space of the digits. So definitely you can get a question. And if you want me to tell the clinical point in the mid thenar space, simple thing, guys. If there is an infection here, if there is an infection here, then how do you drain this infection? How do you drain this infection is that you have to make an incision in between second, third or fourth finger. Okay, I mean, exactly speaking, between the third and fourth finger, if you make an incision, then you can drain the pus. But if there is an infection in the thenar region, then you have to make an incision in the first digital space, in the first web space. Okay, here if you make an incision, then you can drain the thenar pus. Okay. Clear, all of you? Right, guys. So I really don't know. I mean, is there any other class going on, guys? Is there any other class going on, or are there any exams going on? Because in the previous two sessions, there were around 100 people, 100 to 130, 135 people who joined the class. But today, there's shockingly only 30 or 40. So what can be the reason, guys? Can anyone tell me? Is there a problem with understanding or my teaching, or is there really any other class or exam that is going on or you're preparing for? Yeah. They are on vacation. Okay, they are on a vacation. Right. Fine. Whatever it is. Let us continue, guys. Now, okay. Let us continue. Now, I'm going to teach you, because the reason why I'm asking you this is because these topics are very, very, very important, because you might get a lot of doubts in this topic. So if these students, whoever have missed, if they have joined, then it would be easy for me to explain them as well. If they have any kind of doubts, then I can explain it. So you obviously, this lecture will be uploaded. You can watch this lecture later on as well. But the doubts won't be cleared, right? If you have any doubt. Right. Anyways, we are now officially entering into nerve injuries. The most difficult and the most important questions will be framed from this. How many questions? I'll just show you, and then we shall discuss it. Okay. You see, all the way from here till here. All these questions are just the questions of the nerve injuries which were previously asked. Okay. Now pay attention to whatever I'm teaching. Just don't, forget everything. Okay. Just pay attention to whatever I'm teaching. I'll make these nerve injuries so simple for you. Okay. First nerve which we shall be discussing is median nerve, then radial, and then ulnar, and then radial. Okay. The first nerve which we shall be starting is median nerve. First important thing. What is this box over here? Box is that I told you median nerve supplies all your flexors of the anterior compartment, right? Except what? Flexor carpi ulnaris, which is supplied by ulnar nerve, and in flexor digitorum profundus, we have got two parts. Okay, we have got as the medial half, we have got the lateral half. Okay, medial half is also again supplied by ulnar nerve, and flexor carpi ulnaris is supplied by ulnar nerve, right? So guys, let us start now. Are you all ready? And are you all with me, guys? Are you all with me? Let us start now. Right. Very good, Medboost. Very good, Mohammed Yunus. Very good. Now look here, guys. Let me draw this thing. This is your humerus, right? And let me also draw this thing here, that these are your carpal bones. Okay. So you have got 1, 2, 3, 4, 5, 6, 7, 8. And on the surface of the carpal, like a blanket, we have got a retinaculum. This is called as flexor retinaculum, like a blanket. I have already talked this in the carpal tunnel. Nothing new here. Okay. Next important thing is that in the starting itself, when I was discussing this, I told you that within the humerus, here I have got axillary nerve. Okay. And behind the medial epicondyle, I have got ulnar nerve. And exactly from the supracondylar region, this is supracondylar region. Exactly from supracondylar region, the nerve that is passing down is called as median nerve. And also I have told you that if there is a fracture of the supracondylar region, then median nerve will be injured. This thing I told you, right? So just a reminder of that. That's why. So from the center here, the nerve that is passing is your median nerve. Which region? Supracondylar region. Okay. Now look here very carefully. Median nerve comes all the way down. Okay. Does it pass above the flexor retinaculum? No, it passes below the flexor retinaculum. It passes below the flexor retinaculum and comes like this. And that is the reason why, guys, in carpal tunnel, what they do is that down there are carpal bones. Up there is flexor retinaculum. In the center I have got median nerve, right? So flexor retinaculum will be so tight and it will compress the median nerve. So what I will do is that I will cut down the flexor retinaculum and the median nerve is free now. It is decompression surgery. Okay, but whatever. And in the median nerve, I have already told you that median nerve will give a branch that supplies to your thenar muscles. The first thenar muscles which I have highlighted it, if you remember it, right? So these are the first thenar muscles which I have highlighted it. Abductor pollicis brevis, flexor and opponens, isn't it? So it will supply to your thenar muscles, except what? Adductor pollicis. Except what? Except adductor pollicis. Next, it will give the second branch to lumbrical 1 and lumbrical 2. 1 and 2 lumbricals. Next, it will give its third branch. And this third branch is called digital artery. Digital nerve. I'm sorry. It is called digital branch, right? So I told you digital branch will supply your fingers. So it means this digital nerve is supplying to your fingers here. It is supplying to your fingers, not the palmar region. Okay. Now look here. Let us come from the top. What is the important thing? This median nerve will give a branch like this. And this branch is called as anterior interosseous nerve. This anterior interosseous nerve supplies three muscles. What are those three muscles? it gives a branch like this, it gives a second branch, it gives a third branch. And the first muscle is flexor digitorum profundus. Again, just don't write it as flexor digitorum profundus. What? Lateral half of flexor digitorum profundus, because medial half is ulnar now. So lateral half of flexor digitorum profundus, flexor pollicis longus, and pronator quadratus. Now wait a minute, just go back. Flexor digitorum profundus, pronator quadratus, flexor pollicis longus. All these three are deep muscles. Then can I very easily tell you that all the superficial muscles in the anterior compartment are supplied by median nerve, and when it comes to the deep, most of the, all the three muscles are supplied by which nerve? Anterior interosseous nerve. Obviously, leaving the medial half of flexor digitorum profundus. Okay, so this is the thing which you need to remember. Apart from that, median nerve directly supplies which branches? Median nerve directly gives innervation to flexor digitorum superficialis and remaining all kind of flexors, superficial flexors, right? So this entire part is done by median nerve, and a branch of median nerve is anterior interosseous nerve, which supplies the deep muscles. So you have to make these things clear in your mind. Okay, make these things clear in your mind layer by layer. Okay, next important thing, I have already spoke about this, that from median nerve we have got a branch which passes over the flexor retinaculum. Can anyone tell what is the branch that passes over the flexor retinaculum, guys? It passes over the flexor retinaculum and comes like this, and it supplies to your palmar region. Yeah, very good, Muhammad Yunus. Very good. This is called as palmar cutaneous branch. Palmar cutaneous branch of the median nerve. Very good. Okay. Very good. Next important thing is that, let me rub this a little bit and let me put it on the top like this. Okay. Now, from the medial compartment, we have got a muscle, guys. We have got a muscle from the medial compartment like this, right? And this is the muscle here. Can anyone tell me what is this muscle? Yeah. What is this muscle here? This muscle is called as pronator teres. Very good, AJ. Very good. Pronator teres. Pronator teres. Now let us start the game. Now what is the game? The first important thing is that pronator teres. This is pronator teres, and the median nerve is passing between the two heads of pronator teres like this. Okay. So first important thing I am telling you, that if pronator teres is compressed, if pronator teres contracts, then the median nerve will be affected. Can I call this as pronator teres syndrome? And can I also tell that in pronator teres syndrome, the nerve which will be compressed or damaged will be your median nerve, right? So keep that thing in mind. Okay. So pronator teres we have discussed, pronator teres syndrome, PTS. Okay. Next important, look here very carefully now. Whenever there is damage to median nerve, what kind of hand position will I see in the patient, guys? Tell me, what kind of hand position will I see in a patient with a damaged median nerve? Yeah, very good, pharmacist. Yeah, paresthesia pain is there, but I'm asking you, very good, medbooster. See, Benedict sign, pointing finger sign, ape thumb deformity, right? Have you heard of these terms? Clear? Now look here, all of you look here. We are dividing these injuries into three parts. Okay, we are dividing these injuries into three parts. First, if there is an injury at the level of elbow. Second, if there is an injury at the level of wrist. Third, if there is an injury only to anterior interosseous nerve, only and only to anterior interosseous nerve, remaining all are fine. Three things: if there is an injury at the level of wrist, and if there is an injury at the level of elbow. Now look here very carefully. If there is a injury at the level of wrist, it means carpal tunnel syndrome. Now in this carpal tunnel syndrome here, if there is an injury here, what will happen? Thenar muscles are affected. Thenar muscles are affected. So when thenar muscles are affected, look here guys, abductor pollicis brevis is affected, flexor pollicis brevis is affected, opponens pollicis is affected. But out of these three, the important muscle is opponens pollicis. Why? Because abductor pollicis brevis has got longus. Its brother got longus. Flexor pollicis brevis has its own brother longus. But opponens pollicis is a single muscle. It has not got any brothers or sisters. So it is a single muscle. It is responsible for opposition. And if median nerve is cut off, then this finger cannot oppose any finger. Then this finger will remain like this. This finger will remain like this. It even can't move towards any finger. It will remain like this. This is called as ape thumb deformity. What is this deformity called? Ape thumb deformity. Okay. Now, important question is that at the level of wrist, if there is a cut, there will be ape thumb deformity. At the level of elbow also, if there is a cut, there will be ape thumb deformity. Yes or no? Did you understood this point? If there is a cut at the level of elbow, the median nerve is not working, thenar is not working, ape thumb deformity. If there is a cut at the wrist, again median is not working, thenar is not working, opponens is not working, again ape thumb deformity. You understood this thing? Before I move on to the next. Yeah? Very good. In both these level injuries, you will have ape thumb deformity. You will have ape thumb deformity. Okay. Now, a patient is coming to me, guys. Okay. A patient is coming to me telling that, doctor, I have got ape thumb deformity. Okay. Let us say the patient is well educated and he will be telling, doctor, I have got ape thumb deformity, but I don't know where is the injury. Maybe the injury might be at the elbow. Maybe the injury might be at the wrist. Can you please find out? Now, as a doctor, what you should do is that you should tell the patient to flex your fingers. You should tell the patient to flex your fingers. Why? Why am I telling this? Because if there is an injury at the level of wrist, patient can flex the fingers. Why? Because flexor digitorum profundus, flexor digitorum superficialis are working and their both function is to flex the fingers only. But if there is a level of injury at the level of elbow, then flexor digitorum superficialis is gone, profundus is gone, thenar muscles are gone. So patient cannot flex his thumb, patient even cannot flex his fingers. In this way, you can tell whether the injury is at the level of wrist or at the level of elbow. Second point, you understood, guys? You understood this point? Very good. Everyone understood, no confusion, right? Very good. Now look here. Let us write it down at the level of elbow. At the level of elbow, if there is an injury at the level of elbow, look here what will happen. If there is an injury at the level of elbow, there is an injury at the level of elbow here. When there is an injury at the level of elbow, anterior interosseous nerve is not working. Flexor digitorum superficialis is not working. Anterior interosseous nerve and flexor digitorum superficialis, both of them are not working. Okay. Now, flexor digitorum profundus is responsible for the flexion of all these four fingers. And flexor digitorum profundus is divided into two parts, lateral half and medial half. Medial half is responsible for flexion of these three fingers. Lateral half is responsible for flexion of the index finger. Okay, again I am telling, medial half is responsible for flexion of these three fingers. Lateral half of flexor digitorum profundus is responsible for flexion of index finger. So in this patient, which half is not working, lateral half or medial half? Lateral half is not working. Already patient is having ape thumb deformity. Along with that, patient cannot flex his lateral half of flexor digitorum profundus, but he can flex his medial half. Why? Because medial half of flexor digitorum profundus is supplied by ulnar nerve. Here the damage is only to median nerve, not ulnar nerve. So you tell the patient, make a fist. What he'll do is that, doctor, I cannot make a fist because I have ape thumb deformity. Second thing, I cannot close my index finger because my lateral half of flexor digitorum profundus is injured and my medial half is safe. So this kind of finger you call it as pointing index finger. Understood, guys? Have you all understood whatever I told you just now? Yeah? Clear? Very good, guys. Thank you. This is a little bit difficult thing to understand. That's why I was asking you. So I'm not a professor. Shivanshu, I'm not a professor. Thank you, but right at the level of elbow. So at the level of elbow, anterior interosseous nerve is damaged, and not only that, flexor digitorum superficialis is also damaged. Anterior interosseous nerve branch is called as flexor digitorum profundus. So lateral half of flexor digitorum profundus and flexor digitorum superficialis, all of them are lost. Clear? So patient will have pointing finger deformity. Patient will have pointing finger deformity. Okay. So, but if there is an injury at the level of the wrist, patient will not have pointing finger deformity because digital nerve is affected, first two lumbricals are affected, and most importantly, the thenar muscles are affected, which will lead only to ape thumb deformity. Okay. Keep that thing in mind. Keep that thing in mind. So this is very, very, very important. Anyways, I'll make you to do the questions now. You'll understand it. And the third important case is that in some patients, median nerve is not injured. The wrist region, it is not near the wrist region, it is not injured. Near the elbow region, it is not injured. But anterior interosseous nerve alone is injured. This is called as isolated nerve injury. Isolated. Anterior interosseous nerve is separate. So that is injured. If anterior interosseous nerve is injured, lateral half of flexor digitorum profundus will suffer. Flexor pollicis longus will suffer. Pronator quadratus will suffer. Okay. Now, let us make an action. Flexor pollicis longus. Where does it supply? I mean, where does it attach? Flexor pollicis longus attaches here. I have told you number of times. So if this is not working, patient cannot flex his finger. So the finger will remain like this. Next, lateral half of flexor digitorum profundus is attached to which part I told you? Index finger. If that is also not working, patient cannot flex his index finger also. If I tell the patient to do an OK sign like this, I am able to do OK sign because my thumb, I am able to do OK sign because my thumb is flexing, my index finger is flexing. Okay. So patient cannot do this OK sign. He will be doing it like this. He will be doing it like this. Okay. So in case of anterior interosseous nerve injury, keep in mind that patient cannot do an OK sign. Okay. So anterior interosseous nerve injury, OK sign is not possible. OK sign is not possible. Is everyone clear here? Yeah. Look here, guys. This is a patient doing a normal OK sign. This is normal, right? So this is a patient who had got injury of anterior interosseous nerve. Okay, so he's not able to do an OK sign. Clear? This is the important thing. And obviously, this is called as ape thumb deformity. Ape thumb deformity. Okay. Now we are officially done with the median nerve. We are done with the median nerve. Now I'll be explaining you the ulnar nerve. Ulnar nerve. And nothing much to explain about the radial now. I'll just go it fastly. Okay. Ulnar nerve. Now, what is the important thing about ulnar nerve, guys? What is an important thing about ulnar nerve? Look here. Same picture. This is your epicondyle. And by the way, how many ways you can injure How many ways can you injure your median nerve? First way I can injure my median nerve is by supracondylar region fracture. Second way I can injure my median nerve is by pronate teres syndrome. Third way I can injure my median nerve is because of carpal tunnel syndrome. Carpal tunnel syndrome. Three ways I can injure my medial nerve. Clear? Three ways I can injure my medial nerve. Okay. Now let us look on to this thing, ulnar nerve. Coming to ulnar nerve, and from where does this ulnar nerve pass, guys? Ulnar nerve passes behind the medial epicondyle. Okay, I told you previously, ulnar nerve will pass behind the medial epicondyle like this. So this is an ulnar nerve, and by the way, let me also 1, 2, 3, 4, 5, 6, 7, 8. Okay, and obviously here you have got this flexor retinaculum, and here you have got a small canal like this. Small canal. This is called as Guyon's canal. Guyon's canal. This is called as Guyon's canal. Okay. Now, median nerve, how does it pass? Ulnar nerve, it passes behind the medial epicondyle. It passes behind the medial epicondyle. Okay. And by the way, it passes below the flexor retinaculum or above the flexor retinaculum. Tell me. When we were discussing carpal tunnel syndrome, I told you superficial to carpal tunnel. Superficial, SUP. U stands for ulnar nerve, P stands for palmaris longus. Very good. It passes above. It enters into this Guyon's canal, and from here it supplies. It will make a U-turn and it will end at this region. It will end at this region, right? So if I have to draw a simple picture, guys, why? Because this picture is worthy. Let us say this is your thumb, this is your index finger like this, these are your fingers. Okay, let us say he is having many fingers, right? So where is this ulnar nerve ending? Ulnar nerve is ending in the thenar region. Did you notice it? Ulnar nerve is ending in the thenar region. And I have told you already in the starting itself, I have told you, I think, that let me show it to you. In the starting, I have told you that in the thenar region, adductor pollicis is called as graveyard of ulnar nerve. Why? Because adductor pollicis is here. Ulnar nerve passes all the way like this, all the way, and finally ends. Ulnar nerve will end in this adductor pollicis. That is the reason why adductor pollicis is called as a graveyard. This is the place where ulnar nerve ends. Okay, it is called as graveyard of ulnar nerve. Clear, everyone? Yeah. Right. So this is a graveyard of ulnar nerve. And ulnar nerve supplies what all things, guys? It supplies your adductor pollicis, right? It supplies all of your dorsal interossei. It supplies all of your palmar interossei. And when it comes to lumbricals, it does not supply 1 and 2. It supplies 3 and 4 lumbricals. And it supplies all your hypothenar muscles. Hypothenar muscles. Okay. Now another important thing you need to know is that ulnar nerve also will give a branch here in the forearm. What is that branch? Can anyone tell me now? If you have understood this lecture clearly, you will tell me what is that branch which supplies to a forearm muscle. What is that? Two muscles it will supply. Flexor carpi ulnaris. Yes. Flexor carpi ulnaris and next muscle also. Very good, Muhammad Yunus. It supplies flexor carpi ulnaris and medial half of flexor digitorum profundus. Very, very good. Very good. Okay. Medial half of flexor digitorum profundus. And I told you lateral half will flex this finger, medial half will flex these three fingers, right? Remember it. Now, one very important thing. What will happen when ulnar nerve is injured? What kind of position of hand which you can see in a patient? Tell me. Anyone? What kind of position of hand which you can see in a patient? Very good, Dr. Rahul. Very good. Anyone else? Don't tell complete claw hand. Okay. Complete claw hand is done by two nerves. I will tell you later on. Okay. I will tell you later on. Complete claw hand is completely different. Now this is partial claw hand. Okay. Okay. Anyways, look here. All of you know ulnar nerve injury will cause such type of position. This is called as claw hand. Right? Claw hand. Now, normally guys, this lesion is called as ulnar paradox. Why it is called ulnar paradox is that if the lesion is above, this is called as high level nerve injury. This is if the lesion is here, if the injury is here, this is called as low level nerve injury. Okay. As a rule of thumb, high level nerve injuries are more dangerous, are more serious than the low level nerve injuries. But here it is vice versa. High level nerve injuries are less severe here, and low level nerve injuries are more severe in case of ulnar nerve. Clear? That is why it is called as ulnar paradox. Paradox means opposite, right? Ulnar paradox. So upper one should be more injured. Upper one should result in more severe damage, but it will result in less severe damage. Lower one should result in less severe damage, but it will result in more severe damage. Now, what is the concept behind this ulnar paradox? What is this ulnar paradox? What is this ulnar paradox is that? Now listen very carefully, guys. One thing you know, if ulnar nerve is damaged, adductor pollicis, dorsal interossei, palmar interossei, 3-4 lumbricals, hypothenar, all of them, they stop working. So when they stop working, patient will have this type of hand. This is called as what? Ulnar claw. This is called as ulnar claw. Okay. If the level of injury is at the level of wrist, if the injury is at the level of wrist, patient will have ulnar claw. All these muscles are not working, but above the level of wrist, medial half of flexor digitorum profundus is working or not? Tell me, just tell me yes or no. It is working or not working? If injury is at the level of wrist, above the level of wrist, medial half of flexor digitorum profundus is working or not working? Adil, Shivanshu, working. Dr. Rahul Yadav is right, working. देखो अगर इंजुरी यहां पे हुआ, wrist के पास हुआ, तो wrist के ऊपर जो भी चीज है वो तो वर्क करेगा ही. Yes or no? Whatever is present above the wrist, this will work, this will work, this will work. But if injury is at the level of elbow, तो इसके नीचे जितने भी है वो सब they don't work, right? So you understood this. You understood this thing, right? Adil, you understood? Shivanshu, Isha Kaur, you understood, right? So patient is having injury at the level of wrist. Because of that, patient had got ulnar claw. But look here, medial half of flexor digitorum profundus is working normally. So what is the function of flexor digitorum profundus? It will flex the three fingers. So the flexion will be much more severe. This is called a severe form of ulnar claw. You got it? This is called a severe ulnar claw. This is called as normal ulnar claw, less severe ulnar claw, and this is called a severe ulnar claw. Clear? अगर इंजुरी एल्बो के पास हुआ, लेट अस से मीडियल एपिकॉन्डाइल फ्रैक्चर हुआ, राइट? बिकॉज ऑफ दैट अल्नार नर्व इज डैमेज्ड, complete ulnar nerve is damaged, then what will happen? Medial half of flexor digitorum profundus will not work and all these muscles will not work. When they will not work, the patient's hand will be like this. Why not complete flexion? Because medial half of flexor digitorum profundus is not working, so there is no complete flexion. That is why this is called as less severe ulnar claw. Okay, इसीलिए मैंने बोला कि एल्बो के पास जो भी इंजरीज होगा वो लेस सिवियर फॉर्म, और wrist के पास जितने भी इंजरीज है दे आर मोर सिवियर फॉर्म. दिस इज कॉल्ड अल्नार पैराडॉक्स. कंप्लीट क्लॉ हैंड इज डिफरेंट. अल्नार नर्व, मीडियन नर्व अगर दोनों डैमेज हुआ उसको बोलते हैं कंप्लीट क्लॉ हैंड. ऐसे होगा कंप्लीट क्लॉ हैंड. आई विल टीच यू दैट. बट दिस वन, हैव यू अंडरस्टूड व्हाट इज अल्नार पैराडॉक्स? You understood it, right? Everyone, only one is answering here. Mohammad Yonis, Adil, Don, Panditji, Shivanshu, everyone understood Shivanshu. And what about Yonis? What about AJ? What about Lipun, TVD Beast, Sujata Ali, Happiness, Puriya Sadaf, Med Booster, Pharmacist? What happened? Have you all understood? Right. So as you can see these two pictures over here. Now this patient, this is me, not a patient. Okay, this is my hand. So I have made a sign here. Let us say this is a patient. Fine. So this patient is showing this kind of hand here. This is called as ulnar claw, obviously. But this ulnar claw will be at the level of what? At the level of elbow. But this complete ulnar claw is at the level of wrist. Okay, at the level of wrist. Here. Right. So yeah. So what is this condition called as? This is called as wrist drop. Wrist drop. Wrist drop is because of radial nerve. Wrist drop is because of radial nerve. And this is median nerve. And this is ulnar nerve. Okay. Ulnar nerve, this type of claw hand is at the level of, this type of claw hand is at the level of elbow. Is at the level of elbow. ये याद रखो. This is at the level of elbow. Okay. Next important thing. अगर ulnar claw हुआ, अगर ulnar nerve injury हुआ, then what all tests we do? We do a test called as BCDE test. BCDE test क्या होता है? First, B stands for book test. ठीक है? B stands for a book test. What is a book test? Let me show it to you here. Right. So I don't have a book anyways. Okay, fine. So let me, take this remote over here. Okay, let us say this is a book or a card, whatever it is. Okay, card test is different, Adil. Book test is different. So look here. What I'm doing is that, I will give this to the patient. So normally, if a patient is normal, then he will take it like this. But if a patient is having damage to ulnar nerve, then he will pinch it like this and then take it like this. Okay, so this is called as formant sign. What is this called? This is called as formant sign. This is a normal way. This is called as formant sign, or it is also called as a book test. Even if you are taking a book, the patient will flex it like this and take a book instead of taking it like this. Okay, so if you can look at it in the picture, this is a normal patient. This is a patient with ulnar nerve injury. Okay, and exactly what nerve are we testing here? We are testing adductor pollicis. In the thenar group, the last one, graveyard, adductor pollicis. Adductor pollicis is for which test? Book test. Is for book test. And in the book test, what sign is positive? This sign is called as formant sign. This sign is, board is not visible. Right? Book test. This is called as formant sign. This is called as formant sign. Okay, book test. This is normal, this is abnormal. And which muscle are we checking here? Adductor pollicis. Clear, all of you? So after B, next we go to the C. What is C? Look here, ulnar nerve also supplies, ulnar nerve also innervates your all palmar interosseous and all of your dorsal interosseous. Okay, supplies all of your palmar and dorsal interosseous. For example, if I keep a card like this, okay, let us say this is itself a card. Okay, if I give this card to a patient, what will happen? I will tell the patient to put this card in between your fingers and I will start pulling the card. When I start pulling the card, if patient's palmar interossei are working well, if patient's palmar interossei are working well, then he will close his fingers so tightly like this. If his dorsal interossei are working well, he will open his fingers so tightly like this. So well he is opening his fingers. If you are closing your fingers like this is because of palmar interossei. Okay? This is because of palmar interossei. So I put this paper in between his fingers, right? And I'll tell him to close. If my palmar interossei are working well, then even if you pull this paper, the paper will not come out. But if palmar interossei are not working well, I cannot adduct the fingers properly, so it will slip away. You understood this? This is called as card test. What is this called as? Card test. And what do we do for card test for? Palmar interossei. Palmar interossei. Everyone is clear with this, guys? Yeah? Next important, after book test and card test, we have got D. D stands for adductor pollicis. Adductor pollicis, longest test. Okay. And finally, E stands for Igawa's test. Igawa's test. What is Igawa's test? What is Igawa's test is that you tell the patient to put the hand on the table, lift the middle finger and rotate, move the little finger right and left in this way. So if he is able to do this, it means his dorsal interossei are working well. Dorsal interossei are supplied by your ulnar nerve. So if he is able to do this, his dorsal interossei are working well and Igawa's test is normal. Okay, so if he is not able to do this, then he can't move his middle finger right and left in this way. So this is called as Igawa's test for dorsal interossei. Dorsal interossei. Clear, everyone? And all of you have to remember one very important thing, that complete, ulnar claw, ulnar claw, not ulnar claw, sorry, claw hand. I'm sorry, I'm talking about claw hand. Claw hand, not ulnar claw. Ulnar claw is ulnar nerve. I'm talking about claw hand. Claw hand is because of ulnar nerve plus median nerve. Keep this thing in mind. Most of you will get a doubt and you'll put a wrong thing in the exam. Very good, Shivanshu. Ulnar nerve, median nerve together will cause claw hand. But whereas ulnar claw is caused by ulnar nerve itself. So, have you all understood? We shall start doing the questions now. Are you all ready, guys? Are you all ready with the questions? First question. A cut injury of ulnar nerve results in. A cut injury of ulnar nerve results in total claw hand? No. Total claw hand is what? Ulnar nerve plus median nerve is total claw hand. But what is in this case over here? A cut injury of the ulnar nerve results in paralysis of all lumbricals? No. First two lumbricals are median. Second two lumbricals are ulnar. Paralysis of all interossei? Yes. Both palmar and dorsal interossei. This was all these questions were asked previously in your Fmge exam as well. Okay. Ape thumb deformity is seen in. Now you tell me, I told you in the starting, ape thumb deformity is seen in median now. But where? At the level of elbow wrist or only elbow or only wrist? Forearm means at the level of elbow, guys. Okay, don't confuse. Very good. Muhammad Yunus, Dr. Lipun, perfect. Lesion at the level of forearm or elbow, or at the level of wrist. At the level of wrist means carpal tunnel, I told you. So in both of them, I would see ape thumb deformity, both A and B. Very, very good. All the following muscles are paralyzed in injury to medial nerve at the wrist, except when injury to medial nerve at the wrist happens, all the nerves are paralyzed except Adductor pollicis, graveyard of ulnar nerve, injured. First two lumbricals, median nerve, injured. Muscles of thenar eminence, the three muscles are supplied by median nerve, injured, right? And what will be the answer? Come on, you can actually look at this. Abductor is median nerve, adductor is ulnar nerve. Okay, now tell me the answer. Adductor is ulnar nerve, but abductor is median nerve. So the answer will be A. Except is A. Clear? Muscle supplied by ulnar nerve. Palmar interossei is supplied by ulnar nerve, guys. Palmar interossei, yes. Flexor carpi ulnaris, yes. Flexor digitorum profundus, yes. All of the above. But actually they have to give that medial half of flexor digitorum profundus, right? Not lateral half, not complete flexor digitorum profundus. Medial half. Okay. Injury to ulnar nerve in the elbow. Injury to ulnar nerve in the elbow results in ulnar nerve elbow के पास अगर damage हुआ, then problem. What is the problem? Total claw hand है ही नहीं, different. Paralysis of all interossei. Yes, paralysis of all interossei will happen. Yeah. Complete paralysis of flexor digitorum profundus? No. Paralysis of all lumbricals? No. Because why are you answering D? Not D. Lumbricals. First two lumbricals are median nerve. Second two lumbricals are ulnar nerve. यहाँ पे इसने बोला कि अगर ulnar nerve injury हुआ तो सारे lumbricals paralysis हो जाएंगे. नहीं. There won't be paralysis of all the lumbricals. There will be paralysis of all interossei. Okay. Very good. Radial nerve, ulnar nerve, median nerve can be tested using which finger? All the three nerves can be tested using very good. Dr. Lipun, perfect. Muhammad Yunus, excellent. Thumb, very good. Very good, very good, very good. And oryx yeah, look here. Oryx, look here now. Here median nerve. A branch of median nerve is called anterior interosseous nerve. Same way, opposite of that, radial nerve. A branch of radial nerve will be posterior interosseous nerve. अगर posterior interosseous nerve injury हुआ, then patient will have finger drop. Okay, patient will have finger drop. PIN, posterior interosseous nerve injury, will result in finger drop. Finger drop. Okay, finger drop. Okay, look at this question. Following excision of radial head, patient presents with inability to extend metacarpophalangeal joint. ये carpal से, ये metacarpal से. Metacarpophalangeal joint, he is not able to extend it, right? Why? Because there is a drop. That is why he is not able to extend it. So now you tell me, which nerve injury? Very good, Isha Kaur, very good. Injury to posterior interosseous nerve. In a patient with fracture of upper radius, now look here. In a patient with fracture of upper radius and ulna, at the insertion of pronator teres. Pronator teres कहाँ पे insert होता है? यहाँ पे, है ना? From medial epicondyle, it will come like this and insert here. यहाँ पे अगर fracture हुआ, then कौन सा movement is restricted? Which movement is restricted? Pronator teres का function क्या है? Pronation. So patient's pronation will be lost. This was asked in 2018-19, recently, and surprisingly many of them kept it as a wrong answer, you know. Which nerve passes through the medial epicondyle? ये तो आराम से बताओगे, ulnar nerve. Which of the following muscle receives the dual nerve supply? Come on, Chapandi, which among the following muscles receives a dual nerve supply? ఒకటే ఒక muscle, two nerves దానికి supply చేస్తాయి. What is that? Ulnar nerve passing. Very good, Dr. Rahul, very good. Yeah. Flexor digitorum profundus. So can I call flexor digitorum profundus as a hybrid muscle, right? क्योंकि दो nerves innervate हो रहा है, medial half एक और lateral half एक. medial half kaun sa hai? Ulnar nerve. Lateral half enti? Lateral nerve will be median nerve, right? All of the following structures pass deep to flexor retinaculum. I have already told you flexor retinaculum ke niche, flexor retinaculum kinda nunchi, right? All the structures they pass, and okate oka structure, there is only one thing that passes above the flexor retinaculum, and what is that? Excellent, excellent guys. PPP, very good PPP. Palmaris longus, perfect. Which structure passes super? Guys, these questions are asked in your Fmge, right? These are asked. So those are the questions which I kept it here. So which structure passes superficial? Superficial, Pinunchi, what is that? What is that nerve which goes Pinunchi? What is that? Pinunchi nerve. Pinunchi. Very good, very good, very good, very good. Ulnar nerve. Shivanshu Kumar, perfect. Ulnar nerve. Very good, Shivanshu. Okay, very good. Claw hand is due to. Claw hand. Again, remember, not ulnar claw. Muhammad Yunus. Okay, you answered for the previous. Okay. Claw hand is for both median and ulnar nerve. Okay. Claw hand is for both median and ulnar. Okay. Next. Ape thumb deformity is due to injury. मैंने already बोल दिया इसको. Compression of which of the nerves lead to carpal tunnel syndrome? You already know median nerve. है ना? All of the muscles. All of the muscles. Yeah. Tell me this. Then answer చెప్పండి. All the muscles are of rotator cuff except because I have covered this. Very good. PPP, perfect. Except teres major, remaining all the muscles are of rotator cuff. Most common injured muscle in the rotator cuff? Anyone? Most common injured muscle? Tiny, very good. Rahul Yadav, very good. A, supraspinatus, right? Because it is present superficially like this, supraspinatus, right? So, very, very good, guys. Very good, right? Thank you for listening and understanding all the concepts which I taught. By doing these questions, by your answers itself, I can know that how well you understood, right? So this is how they're gonna ask you in the exams, guys. Nothing difficult. The simple thing what you need to do is whatever you have studied, revise it. Okay, revise, 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 revise. You keep on revising, revising, revising. That is the only work you have. Keep on revising, keep on revising, keep on revising, because you will study for 1 week to understand a set of difficult topics, and suddenly you stop revising, then all of them again you have to spend the same time to study all of them. So revision is most important. Second important thing is that a single picture speaks 1,000 words. So whatever you are studying, draw a picture, right? It might be a small topic, it might take at least 3 hours or 4 hours for that topic. Still draw a picture and then learn from that, because pictorial memory is more important. Okay, it is very, very important. When you see it, you remember it. Okay, that is the second important thing. And third important thing is that as the topics are going on, not only in anat, maybe in physio or any subject, as the topics are going on, things get difficult. Now don't give up, because in medicine one very important point is that whatever difficult thing is there, you have to be super perfect of that thing, because that will help you to understand many more topics. I have found this for myself personally, and I'm telling it to you, never ever leave a difficult topic. It is taking 2 days. When I was studying during my second year in physiology regarding the neuromuscular junction, it took me 8 hours to study neuromuscular junction. Until now, I remember everything along with the mechanism. It might take time, let the time waste, okay? But still you'll remember each and everything. That is the third important thing. And fourth important thing is that thank you so much for joining. So have you all understood the class here, guys? Have you all understood? So I hope tomorrow many more students will join. I don't know why only few students have joined today, because tomorrow we are discussing the arterial system, the arterial supply. We shall start on with the brachial plexus and we shall finish it up, and then uh, teach you the arterial system of your upper limb. Okay, that will be very important. And have you understood today's class, guys? Is that clear? Everyone, guys, everyone, your feedback is very, very valuable to me. Yep. Frederick, कल भी same time को 6 बजे, okay, at 6 o'clock tomorrow there will be a live, okay, there will be a live. So that time we shall be discussing all of this, okay. So we shall discuss the arteries. I'm going to draw it and I'm going to show it to you, each and every artery, very, very clearly, guys. That is going to be really an interesting session. So let's wait till tomorrow. Even I'm so excited to teach those things. So love you all, guys. Thank you so much and goodbye.